Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu and we shall continue with our X-ray week. Apologies for the late update, I was a bit held up doing some other duties. So in the previous lecture, we covered the general principles of X-ray. So if you still haven't yet watched that video, sorry about the audio, but you can check down the playlist and I will leave a card right here that you can click on and watch that before you watch this video. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment, share the page and show some support to Zambia and beyond. Grab your piece of paper, your pen, and let's go. So like I already said in the previous review lecture video, we covered the systematic, or rather we covered the technical qualities of a good chest x-ray or a good x-ray before you actually begin to read the x-ray. So in this review lecture, we shall look at a systematic approach of the chest x-ray interpretation. We shall look at a normal chest x-ray and we shall then later on move on to look at abnormal chest x-ray patterns. So remember that before you start reading your x-ray, ensure that you have good demographic details. So the name of the patient, the date when the investigation was taken, where the investigation was taken, the age of the patient, and preferably the gender of the patient. Then you should also assess the technicality of, or the technical quality of the radiograph. So pretty much the placement of the marker on the radiograph, the projection that is taken, you ensure that the patient is well centered. So both the lung apices should be visible. The costophrenic angles should also be visible. All these things I did cover in the previous lecture. You should ensure that the patient isn't rotated. So you should check the distance between the spinous processes and the medial ends of the clavicles. You should also ensure that this x-ray is taken on full inspiration. So ideally they should be 5, 6 with the 7th rib piercing the diaphragm. Those are the anterior ribs, and they should be about 9 to 10 posterior ribs. Additionally, the trachea in children is straight. The scapula shouldn't be in the lung fields, and of course, this x-ray should be adequately penetrated. So you should count about 3 to 4 thoracic vertebrae behind the heart. So having assumed that all these things are in place, that's when we can now begin to systematically read the x-ray, especially with the chest x-ray. So there's what is referred to as the ABC approach. A for airway, B for bones, not breathing, C for cardiac shadow, not circulation. Remember, there's also ABCs when it comes to management of trauma patients. So C is for cardiac shadow and mediastinum, D is for diaphragm, E is for effusions and pleura, F is for lung fields or fields, G is for gastric bubble, and H is for the hilum. Since they are about 1, 2, 3, 4, 5, 6, 7, 8 bullet points or 8 things that we're going to be checking, this lecture is going to be divided into 2 parts. So today we shall cover part 1, where we'll look at the airways, the bones, the cardiac shadow, and the mediastinum. We'll look at the diaphragm, and then in the subsequent lecture we'll look at effusions and pleura. We'll look at the lung fields, we'll look at the gastric bubble, we'll also look at the hilum. Here's a picture of a normal chest x-ray. So you begin with your demographics, which I assume are already there. The marker is present to tell us that this is the left side of the patient. You see that this patient, you can visualize the apices of the lungs. You can visualize the costophrenic angles. You also can see that the distance between the spinous processes to the medial ends of the clavicle is there. So it's equal, and this patient is not rotated. If we count the ribs, the anterior ribs, 1, 2, 3, 4, 5, 6, 7, 8. So they're about 8, with the 7th one piercing the diaphragm. The posterior ribs here are about 9. So this x-ray is taken on full inspiration. We can already see the outline of the vertebra, and we can see them about here. There's another one here. If you really can't see them here, I will leave a link in the description below where I will post these review lectures, the PDF versions of these review lectures there, so that you can download them and have a look at these images much closer. So we'll begin with the airway. Remember that there are 3 anatomical structures that are visible on the chest x-ray. You have the trachea, you have the right bronchus, and you have the left main bronchus. So I will go back to talk about a little bit of some anatomy. so that you can actually know the certain principles. So remember that the trachea is eventually going to descend and bifurcate into two. So it's going to bifurcate into the right main bronchus, which is going to the right lung. It's also going to bifurcate into the left main bronchus, which is obviously going to the left lung. And the angle that is formed between the right main bronchus and the left main bronchus is known as the carina angle, because the cartilage that's present there is known as the carina ring, or the carina trachea. So this angle should be between 60 to 100 degrees. So if it's greater than 90 degrees, then you call that as widening of the carina angle or splaying of the carina angle. Now, another anatomical thing that you really need to take note of is that if you look at the left main bronchus, it's going to be branching off from the trachea at a slightly horizontal angle. So it's going to be angulated. It won't be in line with the trachea. I'll show you an image very soon on the next slide. Whilst on the right side, the main bronchus on the right side is almost in line with the trachea. So it's almost straight down. So it means that when someone aspirates a foreign object, it's easier for it to get to the right lung than it is to the left lung because of this anatomical variation that is present. And also if endotracheal tubes, which ideally should be about 3 centimeters above the carina, if they are advanced too far, they can reach into the right main bronchus. So here is a picture of the trachea in the center, and of course it comes and bifurcates into the right main bronchus, which is almost in line with the trachea, as well as the left main bronchus, which is at an angle. I know this may be very difficult for some of you who are watching these videos for the first time or looking at x-rays for the first time, so I've decided to superimpose certain images. So if I superimpose this is how you are actually supposed to visualize it in your eyes. So you have the trachea here, which is a bit curved in adults, but in children it's much more straight. Then you have your right main bronchus, which is almost in line with the trachea, and you have your left main bronchus here, which is angulated. So those are the three structures that are dealing with the airways. So remember that the trachea is supposed to be in the midline, and there are some pathologies that can cause the trachea to shift towards one side or to be pulled towards the side of the pathology. So there are some pathologies that can push the trachea towards the normal side. There are some pathologies that can pull the trachea towards the affected side. So the trachea can be pushed away in abnormalities like pleural effusions and tension pneumothorax. Remember that inside the thoracic cavity, the lungs are covered by a membrane which is known as the visceral pleura. The chest walls are covered by another membrane which is known as the parietal pleura. And in between there is a pleural space which has some pleural fluid, and this space is a potential space actually where you cannot have accumulation of excessive fluids. You refer to that as a pleural effusion, or you can accumulate excessive air or air in this area. You refer to that as a tension pneumothorax. So if you have this that's accumulating on one side of the chest, it means that it's going to be increasing the pressures on that side of the chest, and this is going to be forcing the trachea to be pushed to the opposite side where there is less pressure. On the other hand, there are some pathologies that can pull the trachea towards the affected side. Like for example, if the lung collapses, it means that the lung is not going to be filling the cavity on the thoracic cavity on that side. So the pressures on that side are much less, so they pull the trachea towards that side. The same thing happens with pulmonary fibrosis because the lung has shrunk and it's lost its elasticity, so it pulls on the trachea. Then sometimes you may have narrowing of the airway, and it happens in conditions like tracheal stenosis. You may also have this in croup, which is laryngotracheal bronchitis, where you have this steeple sign. If you have been to a Catholic church, because what is known as a steeple, where like the building converges to one point. So you refer to that as a steeple sign. I will show you a picture of this later on. So remember that normally the trachea is going to be narrow at the vocal cords. And like I already told you, the bifurcation, which is the carina of the trachea, has an angle of about 60 to 100 degrees, but it can widen. You refer to that as splaying of the carina. Splaying with an L, not an R. So it's splaying of the carina. And there are a few things that can cause this. If the left atrium enlarges, the carina can be splayed. If they have some lymph node enlargement, it can lead to splaying of the carina. Even upper lobe atelectasis can lead to splaying of the carina. And take note that endotracheal tubes are supposed to be placed in the position where the distal tip is about 3 to 4 centimeters above the carina. So the three pathologies that are important when it comes to the trachea is it could be narrowed, it could be deviated, or it could contain foreign objects. So the first thing that you look at on the X-ray after you've done all your technicalities and your demographics of this X-ray, you should look at the airway. So you should ensure that the airway is in the midline, it's not deviated, it's not narrowed, and it doesn't contain any foreign object. So here is what airway narrowing happens. So you can sometimes have subglottic narrowing, that's narrowing below the vocal cords. As we can see here, this airway here seems to be narrowed at this point. That is referred to as a steeple side. That is seen, of course, in croup. Then you may also see narrowing of the trachea in tracheostenosis. But what you actually really need to note is that sometimes this narrowing of the trachea is easy to overcome, especially in asymptomatic patients. So you may think that there is some significant narrowing of the trachea, especially in adults, but this could be due to overlaying of certain shadows that are coming from the mediastinal structures. Then the next pathology is, of course, airway deviation. Remember that the trachea is going to be deviated when you have unequal intrathoracic pressures on either the left or the right side. So there are some pathologies that could push the trachea away from the affected side. So things like pneumothoraces, that's a plural for pneumothorax. You could also have pleural effusions, even a large mass on one affected side. You could also have things that will deviate the trachea towards the side of the pathology. Things like marked atelectasis or collapsed lungs. You could have a lobectomy or a pneumonectomy, pulmonary fibrosis, even pleural fibrosis to some extent. So this here is a pathology that is deviating the trachea away from the affected side. So it means that the pressure that is present here on the left side of this chest has increased. And remember, what could increase the pressure? It's either air or fluid or a mass. But as we can already see from our general principles of X-rays, we say that air is going to be dark. So do you think that this is going to be air? This white area is going to be air? Obviously not. The second thing is that fluids and other tissues are going to appear whitish. So this is most likely that there is some fluid. There's no air that's going to be present in this area. So it's most likely that there is fluid in the pleural space. So that's how you get this massive pleural effusion. How you describe this is known as a homogeneous opacity, or you can call this as a whitening of the left hemithorax, or complete whitening of the left hemithorax. So this is obviously a massive pleural effusion with, of course, deviation of the trachea to the right side or to the non-affected side. Then on this other hand here, you have the trachea being pulled towards this side. And as we can see also here, there's no air because the lung here has collapsed. So here there's lower pressure inside the left hemithorax and this trachea has been deviated towards the affected side. So that's the large difference between these two. It can be confusing, but one key thing that you should look at is where the trachea is. If it's facing away from the lesion or deviated away from the lesion, it's most likely a pleural effusion. If it's facing or if it's deviated towards the lesion, then it's most likely that there's a total lung collapse. Those are the two main pathologies that I want you to be able to distinguish. So sometimes the airway can be deviated due to local displacement. Like for example, you can have some lateral deviation due to mediastinal, even hilar lymphadenopathy in cases like lymphomas, as well as other malignancies. You may also have splaying of the right and the left bronchi by this extreme left atrial enlargement. Remember, I told you that the angle should be between 60 to 100 degrees. So here is some deviation of the rightward deviation of the trachea due to a mediastinal mass, where this trachea has been deviated here to the right because of a mediastinal mass. Most likely it could be a lymphoma. Then here you have splaying of the carina here. So you can see that this angle here is far much greater than 90 degrees, even much greater than 100 degrees. This angle here between the left main bronchus and the right main bronchus over there. And as we can see, this person is like they have had a mitral valve replacement because we can see this ring over here. This is most likely that they had a valve replacement. So they may have had a heart issue. And take note also that this woman, or this X-ray is rather of a woman. As you can see, there's breast shadows that you sometimes shouldn't really miss out on the X-ray, because what you see on the left side should obviously coincide with what you see on the right side. So this was most likely a female patient. So sometimes they may aspirate some foreign objects, like for example in this X-ray where this child has aspirated the foreign object, and it already makes sense that this is going to be lodged in the right main bronchus because of the anatomy. The right main bronchus is almost in line with the trachea. And then probably this shelf support objects are the ones this individual swallowed. It's most likely a child. Then after you assess the airway, you assess the trachea. You assess if it's in the midline, you assess if it's deviated to the pathology or away from the pathology, you assess if it's narrowed. You also assess the angle of the carina, if it's splayed or the angle is normal. Then you move now and assess the bones. So remember, B is for bones. We're done with the airway. So remember the bones that you can see are, of course, the ribs. You have the posterior ribs, which are much easier to see, and they are usually oriented horizontally, and you have the anterior ribs, which are much harder to see and are oriented at an angle of about 45 degrees. You may also see the clavicles, you may see the sternum, which is only visible on the lateral x-rays. The ribs can be seen on posterior, anterior chest x-ray or AP. The clavicle can also be seen there. The vertebral bodies can also be seen, but they are seen much better with the lateral x-ray. So here are the bones that I'm talking about. So here you have your clavicle. Here you have another clavicle here. Here you have your scapula. Here you also have your other scapula. Of course, you have the head of the humerus over there. Then you have your ribs like that. So this is an anterior rib that is, of course, oriented at 45 degrees. You have your anterior ribs over there. You have your vertebral bodies. And then on the lateral x-ray, that's where you can see the sternum over there that I've put a shadow over, and as well as the vertebral bodies over there. This is a lateral x-ray. And then, of course, this is an AP x-ray. Okay. Then what are we going to be checking for the pathologies on the bone? You're going to be checking for the presence of fractures. You're going to be checking for the presence of dislocations. You're going to be checking for partial dislocations or subluxations. You may check for osteoblastic and osteolytic lesions, especially in the ribs, in the clavicles, as well as the thoracic cage in general. We can check also for changes that are happening in the spine and the humerus that may lead to osteoarthritic changes. Remember the mnemonic LOSS. You have loss of joint space, L for loss of joint space, O for osteophytes. These are like bone lips at the edges of the bone. S for subchondral bone cysts, just underneath the cartilage where the bone articulates, you may have some cysts. Then the other S is for subchondral bone sclerosis, where just below the cartilage of the articulation, it begins to thicken a bit. So at this time, you should also check for any for these soft tissues, if there's any subcutaneous air, if there are any foreign bodies, or if there are any surgical clips that are present on the x-ray. And you have to take some caution, because there may sometimes be some nipple shadows that you may confuse for intrapulmonary nodules. So you should compare what you have on the right side with what you have on the left side. So some of the pathologies that I will show you include fractures that may be recent or old, deformities such as kyphosis and scoliosis, sclerosing of the bone, which can be solitary, it can be multiple, it can also be diffuse, lytic lesions, which are like the bone appears like it's eaten up, it's radiolucent, it becomes more radiolucent, so this can be solitary or multiple. And then osteopenic lesions, which are not really recommended to be assessed on chest x-ray. Then I will show you some notched ribs. So beginning with rib fractures, sometimes this may be very obvious for you to see, sometimes they may not be. So if we look at this picture here where it is very obvious, we can see that this rib is fractured here, this rib is fractured here, this rib is fractured there. So this is an AP x-ray. Remember that AP x-rays are less superior compared to the PA chest x-ray. And sometimes the rib fractures may be very, very difficult to spot. So I just want you to have a look at this area here and pretty much tell me where you think the fracture is. Comment in the section below if you are able to find the fracture. Let me even zoom it for you here so that you can see, but there is a fracture where I have put the circle. So you should be able to tell me which bone has fractured. So that's with rib fractures. Then sometimes you may get some old rib fractures that may be suggested if you have focal thickening of the rib consistency. So this may be consistent with callus formation. So as we can see here, this rib here appears much thicker than any of the other ribs. So this most likely could be that there had been a rib fracture and there is some callus formation that had happened. Then with the clavicles, sometimes you may have clavicular fractures, like for example here, the clavicle has been fractured rather, and then you may sometimes have compression of the vertebra. That's on your lateral x-ray. We move on now to deformities. There are two important deformities that I'll talk about, scoliosis and kyphosis. So scoliosis is just pretty much the spine curving from side to side. We can see this on an AP X-ray. We can see this on a PA X-ray. So remember, with scoliosis, the S for side to side. Then with kyphosis, or a hunched back, so the spine is exaggerated from the front to the back curvature of the upper spine. So this is an example of scoliosis. As we can see here, the spine is curving from side to side. So lateral bending or lateral accentuation of the spine. Then with kyphosis, you have this hunched back like that. That's exaggerated front to back curvature of the upper spine. It's often seen on lateral x-rays. Then you may sometimes get a characteristic type of kyphosis, especially that is seen in patients with chronic obstructive pulmonary disorders like emphysema. So you refer to it as a barrel-shaped chest, where you have this kyphosis and this accentuation of the spine from front to back, and then you have this increase in anterior-posterior diameter such that this chest gives you an appearance of a barrel. So if you do not know what a barrel is, just Google a barrel, and I'm sure you'll see some pictures and it will resemble what is being shown on the screen on your video. Then we'll move on to sclerosis. This is obviously thickening or increase in the bone density. So it may be focal, it may be diffuse. Some things that may cause sclerosis include osteoblastic metastasis. You could have some primary bone tumors. You could have various benign lesions like bone lesions or benign tumors like bone lesions. You could have Paget's disease of the bones, obviously, and you could also have chronic osteomyelitis. So the bone will thicken, okay? So you get this x-ray of a patient who has some bone thickening. As we can see here, it's very, very obvious that this bone here and this bone here have thickened. So this is a patient that obviously had breast cancer that was advanced. We can see the nipple, or rather the breast outlines over here. So this is a female patient that had advanced breast cancer that metastasized to the bone. Remember that breast cancer goes and lays down bone wherever it metastasizes. So it becomes a sclerotic tumor wherever it is metastasized. Then sometimes you may get some lytic lesions where there's going to be a decrease in the density of the bone. So this may be solitary or multiple. One of the important causes is osteolytic metastasis with tumors again. You could also have multiple myelomas, some various benign cysts. Then you could also have some Paget's disease. You also could have acute osteomyelitis. So here, TB being one of the more common things that may cause osteolytic lesions on especially the ribs. As we can see here, it's like there's this dark area in this rib that is signifying an osteolytic process, and it seems like there's something going on also in this area. Then we'll come to the other pathology that's affecting bone, which is known as rib notching. So this is like a focal deformity of one or more bones that can occur on the rib surface. So it can occur at the superior surface of the rib, which is much less common. It can occur at the inferior surface of the rib. So causes of superior surface rib notching include things like osteogenesis imperfecta, connective tissue diseases. You could have some local pressure, even hyperparathyroidism. And then inferior surface notching could be caused by coarctation of the aorta, subclavian, even superior vena cava obstruction. Then you could have this happening in post-op patients, especially patients that went for a procedure that's known as a Blalock-Taussig shunt, and this only happens in the upper two ribs. So a Blalock-Taussig shunt is one of these emergency, or rather procedures that we do in children that have tetralogy of Fallot as we wait for them to grow much older. So here is rib notching. I don't know if you can see this from the x-ray, but how you should be able to notice is you should follow the outline of each rib individually. Follow the upper outline, then do that on the other side, follow the lower outline, do that on the other side, and you'll see that there are some bumps on this rib like that. If you still can't see them, then I decided to superimpose another image. So I will superimpose an image and then you should be able to see them very clearly. So this are where the rib notches are. As you can see, there's notching here, there's notching here, there's notching here, there's notching there. So if I go back to that other image, you should now be able to see the rib notching that I superimposed in the next image. So moving on to the other last pathology of affecting the bones, sometimes you may have a cervical rib, which is usually just an extra rib that's going to be arising from the cervical vertebra. It's much more common in women, about 0.5 to 1%, and it can be unilateral on one side or bilateral, both sides, and often it is an incidental finding, but it can cause thoracic outlet obstruction or thoracic outlet syndrome. So here's an example of an individual or a patient with a cervical rib. Then moving on to the next thing, so we looked at the airways, we looked at pathologies affecting the bone, pretty much bone fractures, we looked at osteolytic, we looked at or sclerotic lesions, we looked at rib notching, we also looked at kyphosis and scoliosis. Then we'll now move on to look at the cardiac shadow, and the cardiac shadow can also be referred to as the cardiac silhouette. And at the same time, you should also look at the mediastinum. So remember that there are some important structures, like for example, the aortic arch, which is also referred to as the aortic knuckle. You have the aortic pulmonary window, which is pretty much the space between the aorta and the pulmonary artery. So this is where you're going to be finding your recurrent laryngeal nerve. And some lymph nodes are also found in this area. You also have the left pulmonary artery, the left atrium, the left ventricle, the right atrium, the right pulmonary artery, and the ascending aorta, or rather the descending aorta as well is present. So here are the structures that I've been talking about. So I've superimposed an image first of all so that you can appreciate what I am saying. So you have here the aorta that's going to be ascending in this manner. Then it's going to arch on this side, on the left side of the X-ray. So you will refer to this blob here as the arc of the aorta or the aortic knuckle. Then here you have your left pulmonary artery. The space between the left pulmonary artery and the aortic arc is referred to as the aorticopulmonary window. Sometimes this aorticopulmonary window or aortopulmonary window can be obliterated. Then of course here you have your left atrium. You have the bulk majority of this being your left ventricle. Then on the side of the vertebra you can sometimes see a structure that is descending there. You refer to that as a descending aorta. Then you have of course your right atrium that's peeping on the right side over here, and your right pulmonary artery. So I shall superimpose an image now so that you can have a good understanding of the anatomical relations. So here is a superimposed image. So you have this as your ascending aorta. Then it becomes the arc of the aorta, then the descending aorta, then you have the left pulmonary artery, the aorticopulmonary window in between the two structures, the left atrium, the bulk of the left ventricle, the descending aorta, this one here which is in red, the right atrium which is peeping here on the right side, and you have the right pulmonary artery. So those are the structures that you see of the cardiac silhouette. So here is one now without anything superimposed, but I also have the labels shown on it. So as you can see, you have the trachea over there, you have the superior vena cava coming down there, you have the azygous vein over there, you have the ascending aorta, okay, or the aortic arch over here. The ascending aorta will be ascending in this manner, then it arches there. You have the descending aorta descending there, you have the right atrium over there, you have the left ventricle over there, and of course this is the right hilum, this is the left hilum, and this is the stomach, because the stomach has a gastric bubble in it because it has air. And remember, on the X-ray, air is going to appear dark. So the thing that we look for on the cardiac shadow and the mediastinum is we want to look at the size of the heart. So we want to look at the cardiothoracic ratio. Remember, you should assess the cardiothoracic ratio on a posterior anterior chest X-ray because an AP chest X-ray may magnify the size of the heart. So you want to check for the size of the heart, the position of the heart, the configuration, as well as the heart border. Sometimes you may be checking if they are appropriate size, or sometimes there may even be blunting of the borders. Sometimes there may be a thin rim of air that is surrounding, or a dark rim that is surrounding the heart. You refer to that as a pneumomediastinum. So it could just be surrounding the heart. You can refer to that as a pneumopericardium. Then you also want to check the valves if there's any calcifications or valve replacements. I think I showed you a valve replacement of a ring around that, or valve repair around that on an X-ray much earlier on. So at this stage, you should ensure that you check that the mediastinum isn't wide, because sometimes it can widen due to certain lesions, like for example tumors or even lymph nodes. You may sometimes have inflammation causing this, for example a mediastinitis or a granulomatous inflammation. You may have trauma or even a dissecting aneurysm of the major mediastinal vessels, especially with the aorta. Sometimes the aorta can widen, it can become tortuous, it can also become calcified. Then you also want to check for the superior vena cava, inferior vena cava, and the azygous vein if there's any widening or tortuosity. Or tortuosity just simply means curving, so it starts looking like a snake. So then we'll start with looking at the cardiothoracic ratio. This is usually used to assess whether there is some cardiomegaly also which is pretty much the increase in the size of the heart on the chest X-ray. So the best way to assess for cardiomegaly is, of course, using your cardiothoracic ratio. So you're going to be measuring the maximum horizontal cardiac width divided by the maximum horizontal thoracic width of the inner surface of the rib cage. And then that percentage should be less than 50%. So if it's greater than 50%, then there is some cardiomegaly. And the causes of cardiomegaly, just think anything that can lead to right-sided heart failure or anything that can lead to left-sided heart failure. And please do not mistake pericardial effusions for cardiomegaly. I will show you what pericardial effusions look like. They differ from cardiomegaly. So here is a normal cardiothoracic ratio. So you can measure from here to here the maximum length divided by the maximum length from here to here. So that should be less than 50%. So this is a normal heart. Then here to here is obviously greater than 50% from here to here. So this is obviously cardiomegaly. So with time and more x-rays that you look at, it will become much easier for you to actually assess. Then sometimes you can have some enlargement of specific chambers, because remember that the heart is divided into 4 chambers: right atrium, right ventricle, left atrium, and left ventricle. So you could have enlargement of each of those chambers. You could have enlargement of the left atrium. If you have enlargement of the left atrium, you're going to be having splaying of the carina angle. So the angle will be greater than 90 degrees. I already showed you an image of that with that patient that had the valve replacement. You may also have what is known as a double density sign. Remember that on the chest X-ray, the posterior anterior chest X-ray, the right heart border of the atrium is not visible. The reason why it's not visible is because, the left atrium is not visible. The reason why it's not visible is because of the right atrium. So it lies right in the middle of the chest, and so it's obscured by many structures. So when the left atrium increases in size, it will stretch across the midline and it will create a second line or a second heart border. So you refer to this as a double density sign. And things that can cause left atrial enlargement include things like left-sided heart failure, mitral valve disease like mitral stenosis, mitral regurgitation, even mitral prolapse. So here is an example of a double density sign. You can see that there is a structure here that was placed by the valve. And you can see that here you have 2 heart borders. You have a heart border here. You have another heart border here. You call this as the double density sign. So the border that is furthest outside here is the border of the right atrium, and the border that is pushed out here is now the border of the left atrium. Then right atrial enlargement sometimes can be seen on lateral x-ray. So you get what is known as retrosternal filling of the retrosternal space. Causes of this include things like pulmonary hypertension of any cause. You could have pulmonary valve disease such as pulmonary stenosis, even pulmonary regurgitation. Of course, you're going to have elevation of the cardiac apex. So you're going to have a characteristic boot-shaped appearance of the heart. So you may have bulging of the anterior upper part of the heart border on lateral x-ray. So this is what I mean by retrosternal filling. So you see that this is a normal chest x-ray. You can see that there's still some darkness that you can appreciate behind the sternum. The sternum is in this area here. But here you have this retrosternal filling that is present here. So there is some right ventricular enlargement in this patient. And then, of course, you get this boot-shaped heart, which is characteristically seen in tetralogy of Fallot because there is right ventricular hypertrophy in tetralogy of Fallot. And then moving on to left ventricular enlargement. So the left ventricle is going to be causing depression or lowering of the cardiac border. So the cardiac apex is going to be depressed. So it's going to appear in this manner. So this is obviously a left ventricular enlargement. As you can see, even the size of the heart has increased. So your cardiothoracic ratio has increased. We can also see that there is some splaying of the carina that we can see here to some extent. Then now that I've shown you how what cardiomegaly looks like, or enlargement of the chambers, you now should be able to distinguish it with a pericardial effusion. And remember that not all clinically relevant pericardial effusions are going to be visible in X-ray, particularly if they are developing in an acute setting. So the primary finding that you may see is that you're going to be seeing an enlarged cardiac silhouette or enlarged cardiac shadow. There are other findings that you may see, like for example, a water bottle morphology, which I will show you in the next slide. You may sometimes see an Oreo cookie sign, especially on lateral x-ray. Some causes of pericardial effusion include acute causes such as trauma, viral pericarditis, complications of myocardial infarctions, especially with free wall ruptures, even Dressler's syndrome. You may have some iatrogenic causes such as right ventricular biopsy, even some other procedures that can be done. You may also have subacute to chronic causes such as malignancies, for example, lymphomas, breast malignancies as well as lung malignancies, renal failure, collagen vascular diseases, even hypothyroidism and tuberculosis. So as you can see, this looks like a classical water bottle that you can see. As you can see, this looks, follow my outline of my cursor. So this looks like it's a water bottle. Even this looks like it's a water bottle. So like that. So you refer to that as a pericardial effusion. We'll go into in depth of these things when we look at the subsequent lectures, because I will discuss each section. I will discuss the bones. I'll discuss the airways. I'll discuss the cardiac shadow. I'll discuss the mediastinum separately, but this is more or less an overview on now the systematic things that you're going to be looking at on x-ray, so that you're not lost during the course of the week. Then sometimes you may see an Oreo cookie sign. So as we can see here, you have this area here where it's dark, then you have an area that is light and another area that is dark, like that, giving like an Oreo cookie. So if I place the Oreo cookie, it would be in this manner. Again, I will leave a link in the description to these videos so that you, to the PowerPoint rather, so that you can actually have a look at these images much closer. Then sometimes the heart can be in a different configuration, so you can have malrotation or you can have dextrocardia, where instead of this facing the other side, it's now facing the right side. As you can see, we are looking at this x-ray the right way. And as we can see here, it seems like even the stomach has been moved to this other side, because you can see that there's the gastric bubble here underneath. So whenever you see that all the structures in the viscera have been rotated or have been mirrored, we refer to that condition as situs inversus. Then we come now to the mediastinum, where we check for any widening of the mediastinum, and generally the mediastinum is said to be widened if it's greater than 8 centimeters on AP or PA films. And things that may cause mediastinal widening is a suboptimal taken x-ray, like for example in patients that are rotated, in patients where x-rays are not taken in full inspiration, even in patients where they are taken in AP view. So you have to take note of that, those things that I mentioned in the prior lecture. You may also have some mediastinal masses. So you may be wondering, what exactly is the mediastinum? So we can divide it into predominantly 4 parts. It's divided into an anterior part, which is this part that's shaded, a superior part, which is this part I'm pointing at, the middle part, which is this part, and the posterior part. So there are certain things that could be found in these areas. So if you get a mass that's in the anterior or superior, it could be a lymphoma, it could be a thyroid, it could be a thymus, it could be a teratoma, and you could have an aortic aneurysm, but only in the superior aspect. Then if it's in the middle, it could be due to lymphadenopathy, aortic aneurysms, pericardial cyst, a dilated esophagus, even hiatal hernia. I will show you pictures of a hernia very shortly, or in the subsequent lecture if I don't show it in this lecture. You may also get these in the posterior wall, so or in the posterior mediastinum with neurogenic tumors. You could have even extensions of the mass of the spine. You could have tumors from the spine, even infections. So here's an example of a multinodular goiter. As we can see, you have this mass that is present over there. So this is obviously the goiter. Then here you have a lymphoma that is present. So this lymphoma is present in the superior mediastinum. Here's an image of a thymolipoma, which is a benign tumor of the thymus gland, which consists of fat. You also have obliteration of the retrosternal space here. Then here's a middle mediastinal mass. Of course, this is a pericardial cyst, as we can see this enlargement over there. Then here is an example of a posterior mediastinal cyst. We can see that there is a posterior mediastinal mass, which is a schwannoma. In this case, we can see that there is this white tissue opacity that we can see over there. And of course, this is in a female patient. Then you also have some aortic aneurysms that can be seen. As you can see now, you have this descending aorta that is bulging. As you can see, the descending aorta, the arc of the aorta is supposed to come like that and descend. So this has widened. The aorta has widened. Same thing is happening over there. Here's an example of a pneumomediastinum. As we can see from all the images that I've been showing you around the heart, you can't see any dark line that is surrounding the heart. But if you look at this image, you can see that there is this dark space that seems to be surrounding the heart, even extending through to the neck area there. So this is obviously air in this area. So most likely it's a pneumomediastinum. So pneumomediastinum can be caused by trauma. It can be caused by esophageal rupture. It can be caused by asthma, vomiting, even some neck surgeries, or even baro trauma in things like positive pressure ventilation, and even patients that go diving. Here you have a pneumopericardium, where you have a similar thing, but it's only just limited to the heart. Then This could be due to trauma. It could be due to even bacterial pericarditis secondary to a gas-producing organism. It could be due to post-cardiac surgeries, like, for example, if you placed a pericardial drain as well. It could also be a fistula between the pericardium and the liver, or the pericardium and the stomach, or the pericardium and the esophagus. Then we'll move on now to the diaphragm. So we have discussed the airway, we have discussed the bones, we have discussed the cardiac shadow and the mediastinum. We're now looking at the last part of this, which is the diaphragm. Remember that the right hemidiaphragm is generally higher than the left hemidiaphragm, because on the right side you have the liver, and the diaphragm, which is a plural of diaphragms, which shouldn't be diaphragms here, have a smooth outline and they have a convex upward direction. And you see this angle here is referred to as the costophrenic angle. It is acute and it should be clear. You should be able to visualize it. So there may sometimes be a fat pad at the heart border in obese patients, and sometimes you may have a diaphragmatic hump, which is a localized bulge. This is obviously a normal variant. You may also see the gastric bubble on the left side of the body. If you see air on the right side of the body, that could mean that there is some perforation of viscus. So remember that the right hemidiaphragm is higher than the left. I already said this, due to the liver. So if it's much higher, you should suspect that there is some effusion, or there could be a lobe collapse, or there could be paralysis of the diaphragm, or injury to the phrenic nerve. Remember, the phrenic nerve innervates the diaphragm, C3 to C5. Then if you cannot see the parts of the diaphragm, consider that this could be an infiltrate, or maybe it could be an effusion. And of course, if the film is taken in upright or erect position, if you see air, free air under the right side of the diaphragm, this is going to be significant of intra-abdominal perforation. But there is an exception that I will show you, I think, in the last slide of this review lecture video. Then, of course, the gastric bubble can be seen on the left side of the body. So here are the diaphragm. So you can see the diaphragm here, you can see the diaphragm there. And then on lateral X-ray, they are almost superimposed on each other. Then here's the gastric bubble, okay, as well as intestinal gas that's present there. So sometimes the diaphragm can be elevated. As we can see here, you have elevation of the right side of the diaphragm over there. It's much higher than it's supposed to be. As you can see, we can still see the costophrenic angle here. So it doesn't mean that there's fluid here. But sometimes it could be that there is the liver that has enlarged, for example, in hepatomegaly, sometimes even a subphrenic abscess, sometimes even eventration of the diaphragm. Sometimes you could have phrenic nerve paralysis, or even just a decrease in the lung volume because the lobe has collapsed. Then sometimes you may have pneumoperitoneum, which is now air under the right side of the diaphragm. You see this is known as a double diaphragm sign, where you kind of like have two outlines of the diaphragm because all this is air accumulating underneath the diaphragm. So this is often due to perforated organs in the abdomen, post-operative patients, patients with trauma, even patients who are on peritoneal dialysis. Here's an example of a hiatal hernia where the stomach really herniates into the thoracic cavity. As you can see here, you have this area that is seemingly to be in the position where the heart is. So this is obviously the stomach that has herniated into the thoracic cavity. The same thing here. Here it's even much more clear because it almost looks like an hourglass. So as you can follow my cursor here, you can see the outline of the stomach over there. So this is a hiatal hernia. So the last slide that I will show you is, of course, Chilaiditi sign. So this is obviously known as a gas that's seen between the liver and the diaphragm. So it may sometimes confuse you, or you may mistake this for a pneumoperitoneum, but this is just simply due to the presence of a haustral fold suggesting gas in the intracolic, and this gas is not really in the peritoneum. So you should be wary of this condition and do not let it confuse you that to be air under the diaphragm, it could just be a loop of bowel that has air. It's obviously going to be seen between the liver and the diaphragm. Thank you for spending your time to listen to this review lecture on X-Ray Week. If you haven't yet subscribed to the channel. Drop a like, drop a comment, show some support to Zambia and beyond. Tell a friend to tell a friend that it is indeed X-Ray Week.